Good morning, everyone. I would like to welcome you all to our next IC, which is titled Where Tears Meet Technology, Setting Up a dry eye clinic in Our Everyday Practice. So this session is basically designed to understand why we need our focused attention on dry eye in our everyday practice. So we will be discussing briefly on the basics on setting up a dry eye clinic, followed by the various diagnostic tests to evaluate a dry eye patient, the treatment modalities, case-based discussion, and finally end with the panel discussion. I would like to invite Dr. Sujit Nainar, sir, as one of our panelists for the discussion. Good morning, sir. Yeah, I would also like to invite the other speakers of the IC to just sit on the dais. Thank you.
Good morning, everyone. I would like to introduce the first speaker of the day, Dr. Divya Giridhar. She's an associate consultant in Giridhar Eye Hospital. She's finished a cornea and refractive fellowship from Shankar Netralaya, Chennai. Over to you, Dr. Divya.
Good morning. I'll be talking about the need for a dry eye clinic and role of an optometrist. As we all know, dry eye is considered in today's day as a silent modern age epidemic with a global prevalence ranging from 5 to 50% depending on the geographical location. So there is an increasing incidence of dry eye in today's world due to various factors like the urban lifestyle, increased screen time, aging population, etc. So it affects people of various age groups. And also, not only the patient suffers from inconvenience and irritation, but they also have a serious impact on their quality of life, and it can also lead to a loss in productivity. It is also associated with long-term economic costs since these patients are on long-term treatment, and some of them are even on systemic medication. There is also a possibility to progress to a chronic ocular surface damage, and hence the need for timely diagnosis and treatment. So just a brief recap on the definition of dry eye. It is considered as a multifactorial disease where there are various etiological factors. So a patient presenting to us can either be a symptomatic patient with or without ocular signs, or a asymptomatic patient with or without ocular signs. So it is very important to address both the symptoms and the ocular signs of the patient with detailed evaluation, and finally diagnosing them as either an aqueous deficient dry eye, an evaporative dry eye, or a mixed dry eye. So to evaluate them better or to understand them better is why we need a dedicated dry eye clinic. So a dry eye clinic provides an environment where we can thoroughly evaluate these patients. It provides focused patient care. We can have a more comprehensive approach in evaluating these patients, integration of diagnostic tools under one roof, and finally providing them with customized treatment. So when we have decided to dedicate a space for a dry eye clinic, what all can we include in this clinic? So everything from history to examination and finally to treatment is something that we can include in this clinic. So a basic dry eye clinic can include all the simple tests that we conduct routinely in our OPD, like Schirmer's test, staining of the ocular surface, etc. Whereas an advanced clinic will also include, in addition to these simple tests, you can also include the various diagnostic modalities of the image of the tear film and the meibomian glands. So now we know what we can include in a dry eye clinic. How do we go about evaluating this patient? So first will be history and the administration of the questionnaire. So there are various questionnaires that are available for dry eye. The Ocular Surface Disease Index questionnaire is one of the most commonly used questionnaires. So a questionnaire basically helps us to understand or quantify the problem. We understand how much the symptoms are affecting his or her quality of life. So following the questionnaire and the history taking is when we start evaluating the patient. So the the test for dry eye can broadly be divided into either the non-invasive test or the invasive test. The non-invasive tests basically include the imaging of the ocular surface, that is the tear film and the meibomian glands. So it is always important to understand that before we do any kind of non-invasive test, certain points to be kept in mind is don't instill paracaine, don't stain the ocular surface, don't instill dilating drops, don't do a Schirmer's test prior to this, because all this can disturb the tear film. So following this, firstly we do the non-invasive test. This is basically the imaging of the tear film. This is the ocular surface analyzer, followed by the imaging of the meibomian glands and evaluation of the lipid layer thickness. Following this, the next step would be doing the invasive test like the Schirmer's test and the slit lamp examination. So the slit lamp examination will include everything from examination of the lids to the ocular surface, staining, the corneal staining, the conjunctival staining, examination of the lacrimal gland, etc. So that's where our evaluation ends, and we come to a diagnosis of the cause of dry eye. So a dry eye clinic can also include other customized treatment options like this is the LipiFlow. So this kind of customized treatment option can also be included in your dry eye clinic. So at the end of examination, it is always important to document all these findings. So a performer like this can be created where we can, roughly write every finding that we have found to a particular patient. So by doing this, this includes even the history of any underlying systemic disorders, any regular medications, which can all be risk factors to dry eye. So with this kind of approach, very systematic approach in evaluating the patient, we can prevent either over or underestimating any clinical signs of dry eye, and also monitoring these patients in a more efficient manner. So the entire evaluation is quite extensive and it's quite time consuming in our busy OPD. So that's where there is a role of an optometrist. So an optometrist can form an integral part in your dry eye clinic. One or two optometrists can be trained to take history, to administer questionnaires and also perform various diagnostic tests. So they are conducted in a more consistent manner for all the patients who are referred to such a clinic. They also help in identifying patients who may require detailed evaluation, as the patients usually go to the optometrist first and then they can be referred to a dry eye clinic. Again, as I said, there's a more structured approach in evaluating this patient, and they can also help documenting the findings. So to conclude, a specialized approach enables precise diagnosis of the type of dry eye so that we can provide a more customized treatment for the patient. The term dry eye is often misused, sometimes even misdiagnosed, overtreated. So such an approach helps us to reach a better diagnosis and treat the patient. Also, a lot of patients who are on empirical treatment for dry eye and who don't seem to be getting better, it is very important to identify them for a detailed evaluation and maybe even a systemic evaluation. Thank you. I would like to invite our next speaker on stage, Dr. Aiden Raghunathan. Dr. Aiden is a senior consultant in comprehensive ophthalmology and refractive surgery at Chaitanya Eye Hospital and Research Institute in Trivandrum. Today she'll be talking about the key diagnostic tests and what's new. Over to you, Dr. Aiden.
Good morning, all. Thank you, Dr. Divya and KSOS for this opportunity. I will be dealing with the key diagnostic tests in dry eye. So, the signs and symptoms of dry eye disease are poorly correlated. As such, there is no single gold standard diagnostic marker described for dry eye. And as Dr. Divya mentioned, the sequence of testing recommended is from the least to the most invasive. The TFO's DS2 diagnostic methodology report was published in 2017 along with the revised definition for dry eye. it describes it gives the recommendations under these headings from starting from symptoms to the eyelid aspects. We will start with the symptoms. These are one of the validated symptom questionnaires is recommended. The one which is recommended is the OSDI, which is the most common, the DEQ5, which is shorter, and the Sandy questionnaire, especially for repeated assessments. Next is a visual disturbance, again with the questionnaires, functional testing, and functional visual acuity, which is done with the patient wearing his habitual prescription after 10 to 20 seconds of sustained eye opening without blinking and aided by anesthesia. Next is the tear film stability. Here we have the tear breakup time. It's the interval of time between the complete blink and the appearance of the first break in the tear film. When done with fluorescein to enhance the visibility, it's a fluorescein breakup time. More than 10 seconds is considered normal. And when it's done without fluorescein, it's a non-invasive breakup time, which is typically longer than the fluorescein breakup time. Whenever possible, the recommended one is the NIBT, but since it requires special machines, the FBUT can be used whenever NIBT is not available. Next is the thermography. Based on the concept that evaporation of tear film causes cooling of the ocular surface. So measuring the temperature changes during the interblink period is an index of tear film stability. Similarly, osmolarity variability is also an indicator of tear film homeostasis. Inter-eye differences more than 8 millimosmoles per liter is considered as abnormal. Then the tear volume, the key tests are meniscometry and Schirmer test. Meniscometry is the tear meniscus height, which is measured with special instruments. Normal is less 0.2 to 0.5 millimeters, and less than 0.2 millimeters indicates lacrimal deficiency. Similarly, we can measure the reflection from the convex tear meniscus surface. The tear meniscus radius can be measured with OCT, and it's typically lower in dry eye patients. The Schirmer test is an age-old, well standardized when done with without anesthesia. It can be done with and without anesthesia. Without anesthesia is the standardized one, and the wetting of the filter paper strip is measured. Less than 5 is considered as dry eye, more than 10 is considered normal. And it has a problem with repeatability of the testing. And however, when done with the eyes closed, it is said to be well standardized and repeatable. Coming to tear film composition, the tear film osmolarity is a single best metric described to diagnose and classify dry eye disease. 308 milliosmoles per liter is widely accepted to be more sensitive to diagnose mild to moderate dry eye disease. Now coming to damage to the ocular surface. It's ocular surface staining. Classically described for the cornea with fluorescein and for the conjunctiva with lissamine and rose bengal. But however, with the use of yellow barrier filter, fluorescent staining is said to be better sensitive than the conventional method. It is even compared to for the conjunctival staining, it is sensitive even better than the lissamine green with the yellow barrier filter, with the advantage that just one dye need to be used and no vital staining is required. Next, impression cytology. The cellulose acetate filters are used. The more superficial layers of the epithelium and cells are analyzed. The Nelson's classification system is used. Next is the lip cough. It's the lid parallel conjunctival folds, and this is the area to look for the lip cough. That is, the dashed line is the limbus and the vertical line dropped from the limbus. So that is the area to look for the parallel conjunctival folds, and it is graded from 0 to 3 depending on the number of folds seen. Again, next is the confocal microscopy. It's a non-invasive test. It identifies ocular surface damage at a cellular level. decreased corneal and conjunctival epithelial cell density, conjunctival squamous metaplasia, and corneal nerve changes have been described. Coming to inflammation of the ocular surface. So many inflammatory markers have been implicated in dry eye. The most common ones implicated are the TNF alpha, interleukin 6, interleukin 17A, interleukin 8, and MMP9. Of these, the most common one used is the MMP9, and can be done with a point of care office test. And a positive value is seen when the MMP9 value is more than 40 nanogram per ml. Coming to the lid aspects, first is the lid viper epitheliopathy. It's the area of the lid viper, that is where the lower lid rubs on the conjunctiva. The staining produced is measured. Horizontal length of staining and the sagittal width of staining are measured, and it's graded accordingly. Interferometry, it's an ancillary test. Abnormal multicolored interferometric fringes are seen in dry eye disease. It can also measure the lipid layer thickness, which is normally 40 nanometers. Next is mammography. It gives a morphological assessment of the meibomian glands. The meibomian glands are seen as hyperilluminated areas. In between, the dark areas represent the areas of dropout. Confocal microscopy can also be used to study the eyelid margin. It has diagnostic benefits in obstructive meibomian gland disease. However, it has not been popularly used for dry eye disease diagnosis. So, coming to the clinical protocol for the dry eye diagnostic test battery, these are the TFS2 recommendations. It's a symptomatology, that is DEQ 5 more than 6 or OSDI more than 13, along with one of the markers, that is non-invasive tear breakup time less than 10, osmolarity more than 308, or an inter-eye difference more than 8. Surface staining with more than 5 corneal spots, more than 9 conjunctival spots, or a lid viper epitheliopathy of more than grade 0. Technologies coming, there is an influx of technologies into this field. I'm mentioning the trade names, but with no financial interest. This is the ocular keratograph. It gives a reading of the NIBUT, redness, mammography, dry eye DEQ, and TM meniscus height. This is the ocular surface analyzer, or the IDRA. Then gives the NIBUT, eye blink, lipid layer, TM meniscus height, and meibomian gland loss area. And this is the LiPi view, which gives lipid layer thickness, dynamic meibomian gland imaging, and blink dynamics. In coming to the emerging technologies, lab-on-a-chip systems with multiple biomarkers simultaneously can be tested are in the pipeline. Multiplex tiered assay devices which uses sub-micromilliliters of tears are being suggested, and diagnostic tools to assess reactive oxygen species and oxidized products in dry eye disease. Then technology to determine key pathophysiological factors such as osmolarity and inflammation real time over the whole ocular surface is a future prospect. Another one is the measurement of tear film particle dynamics, where the upward drift of the tear film is measured, and increased wettability, there is increased upward drift. It has been studied in pre-lens tear film in contact lens wearers. It can be used to study the precorneal tear film also. So with all these, where the technology meets the tears, a targeted dry eye therapy is possible. Thank you.
Thank you, ma'am, for taking us through the various diagnostic tests. I would like to invite our next speaker, Dr. Maria Priyanka. Priyanka is presently working as a consultant in cornea and refractive services at Agarwal Eye Hospital, Vellore. She has completed her MS Ophthalm from CMC Vellore and finished her cornea fellowship at Shankar Netralaya, Chennai. Over to you, Dr. Priyanka.
Good morning, everyone. I'll be talking about the treatment modalities, choosing the apt tear substitute, and newer treatment options. Excuse me. So dry eye disease is the most common encountered condition which we see in our OPD, where a lot of overlapping symptoms their patients usually come with. So here is a plethora of symptoms they usually present, but stepwise approach to manage them is very important. We have to diagnose the cause of DD. Knowing the severity of the condition helps us to come to a conclusion on the apt tear substitutes we are supposed to use. So artificial tear substitutes are the first line and mainstay of treatment. The natural tear film is highly complex multidimensional fluid gel solution that ensures normal homeostasis of the ocular surface. Therefore, any artificial tear substitutes which we are using should be aimed at treating the condition and replacing the normal tears. But which one to use? So understanding the components help us to choose that, so that a particular dry eye disease can be targeted and for the best of the patient's comfort. So Barabino et al. Has categorized the tear substitutes into wetting or lubricant agents, which bring about the tear film stability, which includes oiling agents and the viscosity enhancing agents. Then the multiple action tear substitutes improve the quality and quantity of the tear film, and ocular surface modulators interact with the ocular surface and thereby heal the epithelium of the ocular surface, which includes the osmoprotectants and agents which promote the wound healing. So as per the dry eye definition, the words highlighted show the pathology we are supposed to treat here. The first one is the tear film stability can be treated by giving an active ingredient or a viscosity enhancing agents. Loss of homeostasis, hyperosmolarity, and ocular surface inflammation can be controlled by using a biological active excipients. And the third component, which is important in any drop, is the preservative. So in the active ingredients, the main action of them is to wet the ocular surface, retain water, enhance the viscosity, and reduce the irritation. These all bring about a stability in the tear film. These are a list of FDA approved active ingredients. Up to a maximum of 3 can be combined in any ATS. For any ATS which is coming into the market, has to be from one of them. And these include the most commonly the CMC, HPMC, PGPEGs, polymers, which are seen in almost in every drop. Then the next is the biologically active excipients. The main action of them is to protect the promote epithelial growth, anti-inflammatory, and regulate the osmolarity. These include the osmoprotectants, which mainly take care of the epithelium, reduce the apoptosis, improve the healing of the ocular surface. Humectants, which are now in the market, seen in most of the drops, are hyaluronic acid and HP-guar. They not only take care of the epithelium, but also improve the viscosity. Therefore, in some areas, these can be categorized as an active ingredient also. The others are oily agents, surfactants, electrolytes, antioxidants to stabilize the tear film, and agents which promote wound healing. So the last component is the preservative. We know that the preservatives are to reduce the microbial contamination, but we also know that the older preservatives such as BAC, PHMB, EDTA are very toxic to the ocular surface. Therefore, the newer transient preservatives, also called as disappearing preservatives, have come into existence, where when they come in contact with the ocular surface enzyme or the environment, decompose into harmless water, oxygen and carbon dioxide. So even the SOFSIA ionic buffer system, which was recently introduced, also follows a transient preservative rule. Still, if we want preservative free, we can go for unit dose containers or a multi-dose containers, which has a complex cap design, which allows the fluid to flow only in one direction, preventing the egress of the organisms. So the use of ATS should be tailor based. One size fits all would be an oversimplification. So the broad principles of ATS use should be: treat the patient's symptoms, avoid symptom escalation, dilute and remove the ocular agents and inflammatory products on the ocular surface. This is achieved by adopting the following strategies to streamline the approach. So choosing the ATS based on the ingredient. In aqueous tear deficiency, the viscosity enhancing agents are used. Humectants or oil emulsions in the evaporative dry eye. Osmoprotectants when there is hyperosmolarity. Osmoprotectants and hygroscopic agents when there is an epithelial damage. The second step is choosing the ATS based on the severity. Milder cases go for lower viscous agents. More severe, increase the viscosity. Frequency of instillation should depend upon the patient's symptoms. When it goes beyond 4 to 6, it's better to switch to the ATS which have these disappearing preservatives or the preservative-free things. Stepladder approach for milder cases start with one agent and if required other agents can be added, whereas in more severe cases start with the maximum therapy so that you control the symptoms immediately and treat the ocular surface, and then it can be stepped down based on how the patient is and once the ideal point is reached. Role of polypharmacy, we know that a lot of ingredients are there. By mixing and matching on them we can get about the best result and give the best comfort to the patient. Follow-up of all is very important in all the patients, because if any ATS is not working we can switch to the second line or add on a drug again for the patient comfort. So whether it is an aqueous tear deficiency or an evaporative dry eye, first diagnose the severity. Use in lesser cases, for example in aqueous deficiency, use less viscous agents in the early stages. As the severity increases, use the higher viscous agents, and if any epitheliopathy is there or we need to add on, then a biological active ingredient is added. Similarly in evaporative dry eye, using of the active agent and a second line when there is an epitheliopathy, you can add on the biological active ingredients which are osmoprotectants and hygroscopic agents. So few practical tips are, it may not be relevant to be using artificial tear substitutes in bedtime for evaporative dry eye. Using gel ointments at bedtime will be beneficial. Titrate the frequency depending upon the patient's symptoms. Avoid high viscous agents in working individuals. Be aware of all the components, not just the active ingredient. When there is a epitheliopathy, add on a biologically active ingredient and avoid unwanted polypharmacy. So if still after giving all these, if the patients are still not able to be symptom free, then alternative strategies like tear preservation, which include punctal occlusion, tear stimulation with multiple drugs can be done. Control the inflammation with steroids and immunomodulators. Treat the concurrent lid margin disease. Control the underlying systemic condition, and in severe cases, use of Pros Lens, autoserum tears and no growth factors will be helpful. So the newer treatment options, we'll discuss this in three categories. First one is to stabilize the tear film. Second is to control the inflammation and heal the ocular surface. There are certain ways where we can treat the blepharitis and to treat the MGD. So the list is extensive, but I'll be discussing few, and those which are FDA approved. Tiruvaya and intranasal nerve stimulator they stimulate the nerves in the nose and help in increasing the tear production. Cequa and Vivi are higher concentrations of cyclosporin which are in market now, which are used to treat the inflammation. Xiidra is a lifitegrast drug which downregulates the T cell activation and controls the inflammation. Also, we know that serum eye drops are being used now, which contains eye platelet-rich plasma and plasma-rich in growth factors, again to treat the ocular surface pathology and control the inflammation. And there are some treatment options available to treat the blepharitis. Blefex is a medical grade sponge which is held on a handpiece and it spins around at the base of the lashes to clean the eyelashes ends. Zemvi is a solution, which paralyzes the demodex which is on the eyelash and effectively killing the organism. And to treat the meibomian gland dysfunction, we know that a lot of them are there in the market, like LipiFlow, IPL, Tear Care, Meibothermoflow. All these essentially give heat to the meibomian glands, liquefy the meibum, and that is extracted from the glands. Meibo is another drug containing perfluorohexooctane, which increases the lipid layer of the tear film and controlling the evaporation. So I conclude by saying that when considering the efficacy of tear supplements, all of them treat the patient symptoms, some treat the pathology, but none treat the etiology. Dry eye is here to stay. Tear supplements are currently the mainstay in the management of DED, offering the therapeutic benefits. No one class is beneficial or superior to the other. Therefore, having protocols to initiate treatment in mild, moderate, and severe cases should be in place. Thank you.
Thank you, Dr. Priyanka. That was quite an extensive overview of the various treatment modalities. I think we can just, before going to the next talk, we can probably take one or two questions from the audience. If anybody has any questions.
Ma'am, it was a very extensive talk and good talk. And this demodex killing, is it, she told about a paralyzing and killing the demodex. Is it into market and?
It's FDA approved, but I don't think it's available in India.
Okay, thank you.
How long can you give cyclomine?
How long? So, all these cyclosporin or any immunomodulator do take a time to start the action itself, which is usually 4 to 6 weeks. But they say the newer one, Sequa, the onset of action is even quicker because it has some nanomicellar technology. The initial inflammation has to be controlled because once the action starts, it takes at least, it's better to give for 3 to 6 months. And then once the eye is quiet, the inflammation is okay because MGD, once it is treated, continuing the lifestyle modification, treating the regular massages or whatever we advise the patient should be in place. Again, if that is not, then again we reach to the starting point. So that if those things are reinforced after a certain time, I think we can stop the using of cyclosporin.
To your question regarding Demodex, actually I don't think lotilaner is available, but still the current management in our practical setup would be using tea tree oils. Tea tree oils in its concentrated form, not the shampoos which we get. It may not be the correct concentration. And also you can use ivermectin creams. They are actually skin creams. You have to apply it in and around the near the eyelashes and little above and below also, to take actually it is set from the lashes to the eyebrows, this area, so that during the migration of the mites along the skin, and they can get killed. And it is said to be taken for 6 weeks to take care of the entire life cycle of the organism. I don't have any experience.
Not yet. No, when they brought it out, it was quite expensive. You know, it used to be somewhere 25,000 for 1 month's dose. Okay, now they have come down to 2,500. That's it. That's yeah, because of various other reasons. I agree. Yeah, they've recently reduced it to 2,500 for 1 month dosing. And regarding the duration of cyclosporin, there is no definite guidelines, and there is published data to say that up to 4 to 5 years of topical cyclosporin doesn't cause any problems. So yeah, it is based on case to case.
They're also supposed to contain less concentration of probably you can use it as a maintenance therapy. The ivermectin cream is very useful. It's a skin cream. Try to avoid it going inside the eye. Within 1 week, it actually clears the entire demodex. But you are supposed to continue it for 6 weeks, following which you can.
Is it available? Yes.
Lid margins and little below, over to the skin. And after that, probably you can it may come back. So at that time you can maintain it with lid wipes or the shampoos.
Even oral ivermectin has been prescribed for demodex.
Single dose.
And as Dr. Surajini goes for her talk, the diagnosis of dry eye is basically clinical. One very important thing that really helps us is the questionnaires, which is something which we generally don't use in our regular practice. Anand is there. Dr. Anand? Yeah, he's supposed to come here. Yeah. So the problem is, time consuming. So that is where, the role of optometry team and your dry eye clinic comes into play. And, when you have such a busy OP, it's really difficult to sit and get the questionnaire done. It definitely points us towards a, significant symptomatology. And dry eye is basically managing symptoms, except in very, a small niche of patients. Yeah. not even minutes. Okay, it can be less than a minute in most of the. Now that's ambiguity here. Okay, we still don't know why it functions so well when we use it, when we say the retention time is so low.
I would like to invite our next speaker. Dr. Sugranjani is presently working as an associate consultant, cornea and refractive and ocular surface services at Giridhara Institute, Cochin. She has completed her DNB in Narayan Nethralaya and fellowship at Giridhara Hospital. Over to you, Dr. Sugranjani.
Good morning, everyone. It's heartwarming to see a full hall for a dry eye IC, which we did not believe was possible a couple of years back. And this itself clearly shows that dry eye is evolving into a specialty by itself. A dry eye patient is never any ophthalmologist's favorite. So to make my chair time with a dry eye patient a little more interesting, I like to play this game called I Spy with my little eyes with all my dry eye patients, because this is a very common scenario seen in our practice. Most of these patients are mislabeled as dry eye, and as the previous speakers have already beautifully illustrated how to evaluate a dry eye, I would like to show some cases which were mislabeled and not adequately treated for the dry eye symptoms. So my first case today is a 32-year-old female who's a chronic contact lens user, and she gives a history of a recent onset intolerance to contact lenses. Since we have a lot of toys at our disposal right now, we did do her ocular surface analyzer, and you can clearly see that her lipid layer is in red. That means her meibomian glands are not functioning so well, and her non-invasive tear butt is also very low. But she does have a good tear film height. So we did image her meibomian glands, and it is clearly illustrated here that she has meibomian gland losses, which is seen here. The hyperreflective areas are functioning meibomian glands, and some of the meibomian glands are lost. So why does she have such a significant meibomian gland dropout? And as among all the toys that we use, my favorite still is the history taking and the thorough slit lamp examination. So when we did question her about her history, she said recently she started using these retinol cream around her eyes for her wrinkles, started by a dermatologist. And it is very well reported that long-term contact lens use can cause meibomian gland dysfunction, and retinoid cream is also associated with meibomian gland dysfunction. So she was asked to discontinue her cream for some time, and she did improve really well. A thorough slit lamp examination can really help these patients, and slit lamp examination must not be pertained only to the cornea. It must be a thorough ocular surface examination. So a 45-year-old female presented to us with a dry eye, labeled as dry eye, and she gives a history of thyroid dysfunction. Her thyroid profile was normal. So I would like to ask the audience, is there anything specific that you do for your thyroid patients who present with dry eye? Can anyone point any one particular thing that should not be missed in your thyroid patients? If anybody could volunteer. So in a thyroid patient, my favorite thing to do is to lift their lids. So if you retract their upper lids, most of them do have a superior limbic keratoconjunctivitis. In this picture, you can even see this was taken after the treatment was given. So this is very commonly seen in all thyroid dysfunction patients, and they are often mislabeled as dry eye. And in this patient, we just prescribed her a bandage contact lens because she was not keen for a conjunctival cautery. And one clue is that in a thyroid, even if their thyroid profile is normal, it would be better to check their thyroid receptor antibody test, which is more specific for ocular symptoms. Similarly, a 68-year-old female, also labeled as dry eye, presented to us, and when we did examine her, can anyone take a quick guess of what this is? Yeah, she does have filamentary keratitis, and when we did look at her as a whole picture, thanks to COVID, all of them come in wearing a mask, and we don't really look at anything beyond their eyes. So when we did look at her, when she actually pulled her shawl a little down, we can see an enlarged thyroid gland here. So every dry eye patient should be examined in total, and most of them are mislabeled as simply dry eye, and a thyroidectomy helped her alleviate of her symptoms. So this is an 81-year-old female who presented to us. She gives history of anti-glaucoma medication since many years. She was referred for a dry eye evaluation, but Can anyone see what is, okay, so you can see some subtle subconjunctival scarring in her upper tarsal conjunctiva, and also there is keratinization, and her puncta is completely stenosed, and there's loss of plica also. So she was labeled as drug-induced pseudophemphigoid, more commonly seen with patients who have been using anti-glaucoma medication since many years. So unless you do a detailed slit lamp evaluation, you might miss these subtle signs.
One second, before you go to the next, about that case. See, many of us have the feeling that, when the disc is suspicious, when there is a, dilemma, it's safe to start an anti-glaucoma medication. What is lost? Okay, you put the patient on anti-glaucoma and the patient disappears and years later present like this. Okay, once they reach this stage, going back is not easy and practically impossible. Okay, so anti-glaucoma medications are not simple, not absolutely safe. Okay, so before you put the patient on any of these medication, there are drugs which is used once a day, there are drugs which is used twice a day. So we may think, it's such a small dose, what is going to cost? But these patients are going to use that drug for years with resultant problems like this. So unless you are absolutely sure that patient needs the drug, please do not start. Okay, we have seen many cases, we have stopped them because they were on, unnecessary treatment. It's absolutely not warranted or required for those patients, but then they develop problems. Okay, so please be careful. And I tell my glaucoma colleagues, they always come at me with a, stick if I tell them, wherever possible, start preservative free. Or according to me, anti-glaucoma medications with preservatives should be banned.
Thank you for that wonderful tip. So, a 60-year-old male presented to us with a foreign body sensation since many years. I would just like to share his photo. Can anyone take a quick guess on what condition he's suffering from? So this is not very commonly seen. Once we retract the upper lid, usually you cannot see the entire fornix. But in his case, where you can see up to the entire fornix of his eye is seen. So this is commonly seen in floppy lids. So this patient is not actually suffering from just dry eye. His lids are floppy. He needs a lid corrective surgery. So I think this illustrates that, just lifting the lid can give out many clues as to what your patient is suffering from. So he was diagnosed with floppy lids, and lid corrective surgery was advised for him. So most of these post-LASIK patients come back to us with dry eye, and we often dispose them with the first lubricant that pops to our head. But not all post-LASIK patients actually have dry eye. This 29-year-old female presented to us with a headache, and she was diagnosed as dry eye. And when we did a complete orthoptic evaluation for her, we found that she had a low AC by A ratio, and she had a receded near point of convergence. And we advised her to use the Brock string and the pencil push-up test, and she improved remarkably. So in your post-LASIK patients, it is important to even do an orthoptic evaluation in spite of them being 6'6", and most of them may not be suffering from just a post-LASIK dry eye. So staining has been used for long in our dry eye practice, and it helps us document and monitor our patients. It also gives us subtle clues based on the type where the staining is actually present. It gives us subtle clues on what could be the etiology. But staining can also help you pick up those patients who've been wrongly labeled as dry eye. So this 58-year-old gentleman presented to us dryness in the left eye more than right eye. Only left eye is his complaint, and this was his clinical picture. Can anyone take a guess as to what you're seeing? You can see some subtle subepithelial dots in the inferior, cornea. And stain is what helped us pick up what it was. When you stain it, you get a negative stain. So this patient is actually suffering from a recurrent corneal erosion syndrome, and on further probing, he did tell us that he did have a history of trauma in this eye. So not every dry eye is actually a dry eye. So we advised alcohol delamination for this patient, and his symptoms remarkably improved. Our next patient is a 65-year-old gentleman who's undergone a cataract surgery 2 months back, and he was referred for visual blurring in the late post-operative period. He was initially 6'6", but then his vision dropped to 636. This is a very common thing encountered by most of our cataract surgeon, and on history taking, he's on multiple eye drops. Just look at the list of the eye drops. He's on steroids, hypersol, tobramycin, and even an AGM. And when we look at the clinical picture, this is basically a surface toxicity induced by the multiple medications. So it is important to understand this by staining. By staining, we can see this is a punctate epithelial erosion of 3+. And we did do a ocular surface analyzer in him and look at his lipid layer thickness. It's completely low, it's in red. And his non-invasive tear breakup time wouldn't be accurate in this case, but looking at his meibomian glands, he already has meibomian dropout. So this is what contributed to such a severe surface toxicity. So in patients, even pre-operatively, before your cataract surgery, it would be advisable, if you do have a meibography, do it to know the meibomian gland health. We prescribed him a course of doxycycline antibiotic, and we reduced, by simply reducing the topical medications that he was on, he improved remarkably, and his vision improved to 6/9 within 1 week. And we can see that the PEs are clearing. So as Dr. Iredin has already illustrated the various ways of using our toys, the tear meniscus height is measured by the machine in this way. It measures the distance between the lid to the highest point of the tear film. But we must not simply believe these machines also as it is. So 58-year-old male patient comes to us diagnosed as dry eye since 1 year. Main complaint is watering and foreign body sensation. So we did do the ocular surface analyzer and look at the tear film height. It's in yellow. We very rarely see this. So when you see a very high tear film height, we must remember that the machine measures the tear film height this way. So in this patient, this is what we saw. Can anyone take a guess of what this is? There is, of course, an increased tear film height, but there is something that is causing it. This is just an inferior conjunctival chalasis, which is giving a wrong value for the tear film height. So in a patient of dry eye, if your tear meniscus height is shown to be very high, always look for conjunctival chalasis, and we must not believe these machines blindly. And we advised excision of the conjunctival chalasis, and that remarkably improved the symptoms. Blink rate is a new tool which these tools have made it possible for us to analyze the blink rate. And a 22-year-old young male comes to us with dryness, and he gives history of recurrent lid lesions. So when you hear this recurrent lid lesions, your first thought is going to be maybe he gets recurrent styes. So we did do the imaging of the meibomian gland to look for meibomian gland dysfunction. As you can see, his meibomian glands are spectacular. There is no dropouts. His lipid layer is fairly okay, but look at his blink rate. They are really high. They are very high for this patient. And we just put him back on the slit lamp and looked at his slit. I don't know if it's clearly seen. So he had this viral wart. Okay, so this was what was causing this recurrent irritation in him and making him blink a lot more and giving him a feeling of dryness. So a simple removal of the viral wart by excision made him improve. And we do get patients like this, like a 54-year-old female patient who presented to us post a ptosis correction. And this was her clinical picture. This is what you would see in probably a neurotrophic ulcer or a patient with exposure keratopathy. These machines can actually help you diagnose these better. So if you can look at her blink rate, it is nearly nil in both her eyes. And even the 2 or 1 blink that is there, out of that 2 and 1 are partial. So another thing that I would like to highlight is in a patient with a low blink rate, their lipid layer will be falsely high, because as we know, the lids is what spreads this lipid layer across the ocular surface, and when there are no blinks at all, the first recorded lipid layer just remains there. So they will be falsely high. So this patient had a poor blink-induced exposure keratopathy. This can be seen in post-ptosis correction, and a simple tarsorrhaphy helped her improve her symptoms. Another case on the similar lines is a 30-year-old male patient who presented with severe dryness in the right eye, and he had undergone congenital ptosis correction in the past. And again, look at his blink rate. most of in the right eye. So he has 6 blinks, but out of the 6 are also partial. But look at his lipid layer. It's very falsely high. That is because there is no blink to distribute this. So these are partial blinks induced by secondary to ptosis correction. So this patient is also suffering from a exposure keratopathy. And we do rarely have such patients, a 34-year-old male patient who's a self-proclaimed poor blinker. His complaint was that he has dryness and he knows that he blinks very poorly. And he was true to his word. When we did do the test, his blinks were 0 in both eyes. And again here, I would like to highlight that his lipid layer is falsely high. So you cannot tell this patient that you don't have evaporative dry eye because you have a good lipid layer thickness. So what we did advise this patient is, now we do have blink apps on our phone which can be installed on your phone. So when you're scrolling through your phone, every 30 seconds it gives you an notification that you need to blink. So there are newer tools available to us at our disposal, and we must use it in a toto to help these patients feel better. Thank you very much for your patient listening.
Thank you, Dr. Sugaranjani. That was indeed a potpourri of interesting cases. If anybody has any questions, I would also like to invite Dr. Anand to please. I think sir's left, okay. If anybody has any questions, we have another 5 minutes, I guess.
You have very validly, you have covered all the valid points, especially in the history. One point I would like to stress is the intake of the systemic medicines, which I think first 1 or 2 slides you have shown. It's very important. Most often we miss, and if we follow a proper questionnaire, we may not miss it actually. Most of these patients, especially those using antipsychotic medicines, they have a very bad effect on the tear film. And since they have dry eye, they become more psychotic. They take more tablets, and ultimately it's a vicious cycle. So most of them, like what Vinay told, they have a permanent damage in the tear film. In spite of stopping the medicine, we may not be able to recover the proper tear film. That's a very good point. And I like the blink app also.
So one question which is usually asked is, what is the need for all these gadgets? I think it's been very clear from Dr. Sugaranjani's presentation. Yes, dry eye is basically a diagnosis, a clinical diagnosis, but then now it has evolved for us from just having Moisol drops to the plethora of drops and other things which we have now. Now we can treat at least with whatever knowledge we have, we can kind of channelize direct treatment to one particular thing. For that to happen, we need to have a proper, evaluation and, backup of many of these gadgets. Yes, they are quite expensive, but then they do have significant role in, in present age, where you have a lot of people on monitors and other things which comes to you with various kinds of symptoms, and to channelize them, to put them into different areas and see what is the real problem and what is the right kind of treatment they require. We need to have these things. Thank you.
Probably to give an objective assessment to the patient so that they are convinced and they tend to continue the treatment, or they are at least convinced with what we are saying actually. One thing, Dr. Divya, to both of you, like in Giridhar, if you have a dry eye clinic, so the one dues to a protocol which they have shown, the triaging. The triaging is done by optometrist, or where does this optometrist actually fit in for the dry eye clinic?
No, so we have trained a couple of optometrists to to do the various tests like the Shermers and all the imaging tests. So we have taught them how to do it. So there's a consistency in how the tests are done.
My question is, the patient comes to your clinic. First, definitely they will go through the refraction part.
Yeah. So
and
if they
NCT,
feel
and then
no,
so
so
before
they call
seeing the
us.
doctor.
Yeah, if they feel any patient is
So
very
who says that
symptomatic.
he or she is a dry eye patient?
See, before answering that, the small difference in our setup is our people are optometrists, not refractionists. Okay. they do a clinical examination. Okay, they do a full clinical examination of the patient, of a routine walk-in patient, and by the time the patient comes to the consultant, okay, the patient is dilated. Okay, so that amount of workup is done by the optometrist. Okay, so they are trained in basic clinical examination of these patients. Okay, so when a new patient walks into the clinic, and the first point of contact is our optometrist, and from the history and the preliminary examination, if the optometrist feels yes, there is a significant, dryness or whatever it is, there is a role for dry eye evaluation, then the patient is sent to the dry eye clinic with the consent of the patient and the consultant. Yes. Only if either refuses, it goes to the consultant, and then the thing happens.
So that this happens before any of these invasive.
Yes, yes, yes.
That's the key part.
And that is the most important thing that has to be highlighted. Once you touch the surface, then you do, whatever it is not going to be absolutely truthful. Correct.
So they do a slit lamp examination to document staining and everything, and then the patient comes back to us. Then we also examine them and then do the final diagnosis. And
Sorry, sir. Actually, I missed the first part. Maybe you have explained it. You were telling like optometrists were checking the patients first. So 2 or 3 cases now Sugaranjini was showing, like what recurrent corneal erosion, conjunctivochalasis and all. So did they gone through all the dry eye evaluation first and later we picked up these features, or how it is like?
No, luckily no. So most of those kind of patients were referred to me from elsewhere. And usually those were referred cases from other consultants within the hospital. So these cases did not undergo dry eye. That's why I did not show the scans.
Okay.
So it's not that every patient of dry eye goes for these scans before seeing us. More than 70% of them come to the consultant first, and then we see the entire, as sir said, even the optometrists are trained in a good slit lamp evaluation. So they do come to us, and after we do the evaluation, we can send them for the scans also. But in the initial evaluation, if we do feel that this does not require a dry eye evaluation, we do not send them for the scans. So the floppy lid, recurrent corneal erosion were referred to me from other consultants in the hospital itself. So I didn't do the scans for them.
Okay, thank you.
Thank you everyone for attending our IC. Before we finish, I also just want to thank Dr. Priyanka for being a part of the IC, and please accept a small token of appreciation for being a part of the IC. I would also like to thank Dr. Sujit and Vinay sir for being part of the panel discussion. Thank you, sir.